I'm Jack Farr. I'm a knee specialist, and my subspecialty interests are cartilage and patellofemoral disorders. And that sort of got me into the biologics because a lot of these people they're bad enough to have symptoms, but they're not ready for surgery. Stem cells, to be clear, are not truly stem cells. So we're going to use that as a term that everybody throws around. They're really pluripotential cells, and what they do is modulate the environment of the joint or whatever tissue you're putting in. So if it's too inflamed, it'll decrease the inflammation. If there's too much destruction going on, it will decrease that amount. So there's a balance. You're saying, well, what about destruction? Well, we all have skin cells that are being destroyed on a regular basis. We all have platelets that are being destroyed on a regular basis and replenished. So destruction is not a bad thing. It's when it gets out of balance. So that is the goal of these MSCs. Platelet-rich plasma, on the other hand, does not have those cells. It has only platelets. Platelets have a lot of different proteins, which are factors that can be anti-inflammatory, anti-catabolic, so anti-teardown. And so these can modify the environment. You're going, well, both of them are modifying the environment, and that's exactly what we want. We want to take a knee that is way out of balance. It's way too inflammatory, way too catabolic, and we want to bring both of those down and moderate it. And right now, do we know which one's best? There's actually more studies that support PRP, but there's ongoing research with these pluripotential MSCs. So this is how it comes. This is the actual product. It's frozen. We thaw that out. Add saline to it and end up with 4 milliliters that we would inject into the knee. So when we're looking for an optimal candidate for either pluripotential cells or for PRP, what we want is somebody that has moderate arthritis. In fact, most of the time, these are not people who are looking at a total knee arthroplasty as the next step. Because the people throughout, it doesn't matter whether you're giving steroid, viscosupplements, or these biologics, the people who do the best have enough arthritis to actually have symptoms, but they're not bone on bone. So this is an example right here. You can see this person has a good joint space on the outside of the knee. On the inside, it's narrowed. You can compare those two. It's narrowed by about 50%. On this side, it's even narrowed a little bit more than 50%. And so these both have joint spaces, but there is narrowing. And I've found that patients do best, they're the best candidate, if they have mild to moderate joint space narrowing, and they have activity-related discomfort, and they have intermittent effusions or swelling of the knee, because those are the things that these injections can alter. If it gets down to bone on bone, some of their pain is coming from the bone, and injection into the knee is not going to address that. So to learn more about our services at OrthoIndy, especially our biologics program, I'd encourage you to subscribe to our YouTube channel.